Assalamu alaikum students, and welcome to your Ophthalmologic Lecture video sessions. Today we are starting off with a brand new theme of the red eye, and we'll be talking about the first three disease entities in that theme: conjunctivitis, episcleritis, and scleritis. The red eye is named as such because the patient develops a red eye, and that is what alerts him and brings him to a doctor. Most of these entities are associated with pain, from mild pain to a pain that's been described as third worst type of pain a patient can experience. The diseases that we'll be doing today are relatively painless, associated with mostly a discomfort, with the exception of a type of chronic conjunctivitis and scleritis, which do have pain associated with them. So we'll first talk about the relevant anatomy, then we'll talk about the classification of these diseases, their types and patient presentation, and finally their management. Starting off with the anatomy, the conjunctiva and the Epi Sclera both begin at the limbus. The limbus is a transition zone between the cornea and the sclera. This cornea is not covered by the conjunctiva or the Epi Sclera. The cornea has its own epithelium. Both the conjunctiva and the Epi Sclera begin at the limbus. The conjunctiva more so anteriorly as compared to the Epi Sclera, but none of these two cover the cornea. That has to be really clear, and both of these begin at the limbus. So if you see this picture, the topmost layer is the conjunctiva, followed by something called the Tenon's capsule, and then Epi Sclera. So the Tenon's capsule is a fibrotic tissue that basically ensleeves or ensheets the muscles from their origin to their insertion, so the muscles can move with as less of a friction as possible and can perform optimally. The Epi Sclera is basically a thin covering that covers all of the sclera, all the way from the optic nerve to the limbus. That leaves the conjunctiva. The conjunctiva does begin at the limbus, but it doesn't continue all the way back, and it sort of has its own orientation, which we'll just discuss here. So this is the conjunctiva as seen in an eye, and this is just a picture to show you the different bits or the zones of the conjunctiva. The conjunctiva, basically, as we said, begins from the limbus right here, and the part that covers the eyeball is called bulbar conjunctiva, which is shown in yellow color here. It then continues into a little pouch, which is called the conjunctival fornix. The conjunctival fornix can't be seen. It's right here in this little crease, because it's in that little space between the orbit and the bony orbit and the eyeball. It then continues to line the undersurface or the posterior surface of the lid as palpebral conjunctiva. So bulbar conjunctiva from the limbus surrounding the eyeball to a conjunctival fornix, which is basically a reflection of the conjunctiva into the space between the orbit and the eyeball, the bony orbit and the eyeball, and then it finally reflects back onto the posterior surface of the lids as palpebral conjunctiva, which is shown in green here. So this is how the conjunctiva is sort of oriented in the eye. This is the Epi Sclera. We'll talk more about the Epi Sclera when we talk about episcleritis. It's basically composed of a lot of fibrous and elastic tissue, and it's very vascular. And its job is basically to provide nourishment to the sclera, which is sort of relatively avascular as compared to the Epi Sclera, because the function of the sclera is protection, and any tissue designed in your body to have protection has sort of little vascularity, like for example your bones, which are supposed to provide you with your skeletal support, are relatively avascular, apart from the marrow, which performs a very different function. But the structure of the bone, the periosteum, is its vascular or nourishing layer. So the Epi Sclera is basically the nourishing layer for the sclera. So the first, we'll start off with conjunctivitis, and conjunctivitis is basically inflammation of conjunctiva. Conjunctiva is basically made up of a lot of cuboidal cells and goblet cells, so it produces mucus, which forms a component of your tear film. So whenever you have inflammation of the conjunctiva, your tear film is disrupted. So this is what conjunctivitis is classified as into infectious and non-infectious types. At an undergraduate level, the infectious types we do are viral and bacterial, and they are the most predominant types. And the non-infectious type that is really important is the allergic variety or allergic conjunctivitis. And irrespective of any of these, types of conjunctivitis like allergic or non-allergic, acute or chronic, they're all associated with a little bit of discomfort, which might be perceived as pain by a patient because Even a little bit of a foreign body sensation or discomfort can be perceived as a pain, because any symptom in the eye which is really apparent to the patient is of concern, because they think, oh, this might lead to blindness. We have discharge of various types depending upon the type of inflammation and irritation. And irritation is in part due to the inflammatory processes and also because of disruption of the tear film that we talked about. Chronic conjunctivitis, in addition to what we have already discussed, may also present with real pain, something that is between a foreign body sensation, something that you also feel in acute conjunctivitis, to frank pain and decreased vision as well. And we'll see why that happens as we talk about those disease entities. So there are certain specific presentations that help to differentiate between various types of conjunctival inflammations. Remember, in all conjunctival inflammations, the eye would present as a red eye. So redness as a way of differentiating between types of conjunctival inflammations is pretty much out, because all these eyes are going to be red. So we depend upon certain additional signs that are easy to pick up, i.e. could be picked up on a torch examination or at most an ophthalmoscopic examination, because those are the tools of the trade of an undergraduate or a family physician. That is what you are being trained as. So itching is primarily seen in an allergic conjunctivitis, papillae formation primarily seen in allergic conjunctivitis, follicles seen in viral conjunctivitis, and trachoma. Trachoma is because of an atypical bacteria, which is obligate intracellular, and perhaps that is why it also produces follicles, because viruses are obligate intracellular. Scarring is seen in various types of chronic conjunctivitis, and finally lymphadenopathy is seen primarily in viral conjunctivitis and again in trachoma. So we'll start off with allergic conjunctivitis. It is really important, especially in Pakistan, and especially in Islamabad, because of an abundance of allergen-producing flora. A lot of trees in Islamabad are notorious for producing allergies, not only ocular allergies, but nasal allergies and respiratory allergic illnesses as well. So allergic conjunctivitis, that we discussed before, could be acute and chronic, and they are basically type 1 hypersensitivity reactions. And the most common environmental allergens are basically your pollen and your dust. And Islamabad has a lot of pollen and has also started accumulating a lot of dust. Eye makeup and contact lenses are also sort of culprits that can lead to allergic conjunctivitis. So this is just the type 1 hypersensitivity reaction. I'm not going to go over it. You would know it better than I do right now, since you talked about allergies and hypersensitivity, discussed these things, not talked about them very recently. In fact, maybe just last year, or for the last 3 years, hopefully. So this is how allergic conjunctivitis is classified as, and it might look very elaborate, but it's honestly very simple. It's basically of an acute or a chronic variety. Of the chronic variety, we have vernal Corado conjunctivitis, which is the most important, and giant papillary and topic are something that we'll also discuss. The acute variety is even simpler. It's either seasonal or perennial. A seasonal type of an acute allergic conjunctivitis is something that comes in specific seasons, especially spring and summer. And perennial is something that lasts all year round but has exacerbations with symptoms, with seasons. So you would have a little bit of an itchy eye all year around, but as summer and spring come, symptoms certainly go really, really bad. So how do these patients present? Itching is, as we talked about, is a sine qua non. No itching, no allergies. And itching is basically because of release of histamine. Photophobia is because of disruption of tear film and inflammation of the conjunctiva. Remember, conjunctiva produces mucus, which is a component of your tear film. And when the tear film is disrupted, you get photophobia, because the tear film provides a smooth front layer to the cornea, which helps and aids in refraction of light, smoothing out the surface of the cornea. And when you don't have that layer, that light that is striking the cornea directly causes a little bit of a discomfort, leading to photophobia. Conjunctival congestion, obviously, it's going to produce a red eye. It's an inflammatory reaction. The type of discharge you see is mucoid and has been described as ropey by patients or stringy by patients. And that is because of the fact that it has a lot of mucus in it, and that is being produced because of the action of histamine. So it's a ropey discharge. Patients usually say, I'm trying to pull out strings from my eye. If you have little kids, they would say that there's a spider web in my eye. Most people in Pakistan would say, aankhon ke aage jale aate hain, like webs in front of my eye. The other characteristic sign is a papillae formation, and papillae formation are localized edematous small elevations of the palpebral conjunctiva. And this is basically a vasodilatory effect of the inflammatory mediators, histamine, which results in edema of the palpebral conjunctiva. And since the palpebral conjunctiva is very tightly adherent to the surface of the lid, it just produces little pockets wherever it can sort of find an opportunity to sort of pop out. These are what papillae looks like. They're small red elevations. So this is an example of a papillae. And again, this is because of vasodilation and edema of the palpebral conjunctiva in response to release of histamine. Very, very characteristic of an allergic reaction. This is the mucoid discharge. To differentiate between a mucoid discharge and a mucopurulent discharge, just look at the color. A purulent discharge is more yellow, or a mucopurulent discharge is more yellow, and mucoid discharge is basically white, as shown in this picture. And this is what patients say, that they're trying to pull strings out of their eye, because to them it appears that there are strings, and this is basically that strand of mucus that they're trying to pull out of the eye. So management. Acute allergic reactions are not the most difficult conditions to manage. You just have to effectively communicate with your patients. Remember, your communication skill is just as important as your clinical competences. So you need to tell the patient that this is not a curative disease. It is because of something in the environment. And unless you can change your environment and go to a place where there are no allergens that you're allergic to, this thing will continue to happen. But this is not the end of the world. We can easily control the symptoms when they occur with very simple treatments and even remedies. Then we need to explain to them the harmful effects of certain drugs, especially steroids, because ophthalmologists, family physicians love prescribing steroids, thinking that mild steroids are not going to cause a problem. Every type of steroid can cause a problem, provided it's been used for long enough. I have had students in the past who have been prescribed steroids without giving them a cutoff date, or even being told this is a steroid, or being told that use it carefully or use it for a fixed time. They just gave it. Steroids work wonders. Patients usually think, oh, we'll just forget everything else and we'll just keep using these. These days, there is more awareness because of the abundance of information, or information that's available to everyone. I mean, Google, you write steroid side effects IN. There we go. You can just write the name of the drug and it'll tell you what drug it is. Is it? Even trade names that are very specific to Pakistan, you Google them and they pop up telling you what's in the drug. So if it is your responsibility to inform your patients what you're prescribing and the most adverse effects of drugs. But the thing that I'm talking about right here is you don't need steroids in most cases of acute conjunctivitis. Effective communication with your patient, together with using an antihistamine with a decongestant for as long as the allergies last, and then an additional 3 to 4 weeks just to make sure that the histamine is sort of washed out from the system, works wonders. You can also prescribe mast cell stabilizers as a prophylactic measure. So you tell them, look, your allergies begin in March, start using this in Feb. Continue using this throughout the allergic period and maybe 3 to 4 weeks after that. Because mast cell stabilizers work best when they act before mast cells degranulate and release histamine into the system. You can prescribe them once the allergic reaction starts, but they will not be as effective as they would be if you use them before the allergic season starts. The good part is we get a lot of drugs that are multi-action, olopatadine and ketotifen, that are doing most of these things. Olopatadine is an antihistamine and a mast cell stabilizer. Ketotifen is an antihistamine, a mast cell stabilizer, as well as a weak decongestant. So it can do all of these things. And you use it as the patient requires up to 4 times a day. Olopatadine is simpler dose. It's once a day for children, twice a day for adults. But you see, it's just a single drug. Supportive measures that can be taken together with the regular treatment in a setting of an allergic conjunctivitis, regular treatment would be anti-allergy, antihistamines, combination drugs, would be the use of lubricants. Lubricants play a very important role in managing the severity of symptoms of an allergic conjunctivitis. A, because excessive mucus production does disrupt a tear film, and use of lubricants would sort of help reform the tear film better. In addition, cool compresses and ice packs are also something of use, simply because they reduce the effects of inflammation in the eye. Both lubrication and cool compresses can be used as often as possible, and should be encouraged to be used as often as possible. For severe attacks and for exacerbations, you might want to prescribe a steroid to your patient, but that has to be a well communicated prescription, in the sense it has to be for a period that the doctor says it's for, and the doctor clearly has to communicate the side effects, the exact duration, which has to be limited, not unlimited, only until the acute exacerbation or that real severe sort of attack subsides. So it requires not only a prescription but a close, quick follow-up, and also informing the patient that you need to taper it. You just can't discontinue the drugs to prevent effects of steroid withdrawal, even topical steroids. So tell the patients that you might have adverse effects of the drug if you use it for a prolonged period. In spite of the fact that this controls allergies really well, it can cause cataract and glaucoma, and we have talked about those diseases in relation to use of steroids. So limit them. Don't give it to the patient that's coming to you for the first time as a family physician or general practitioner, thinking, hey, it'll really help the patient and he'll say that this doctor knows his medicine. You don't know your medicine if you're using this as a first-line drug. It's not a first-line drug. It's a drug that is to be used when none of the other drugs are usually working. And if you communicate really well to your patients, and use supportive measures in addition to the regular treatment, it does work. Don't prescribe steroids as a first-line drug. It's not a first-line drug. Other measures that you can also take with this, and we'll also discuss them in a setting of chronic allergic conjunctivitis, is the use of sunglasses and caps, which also help reduce the effect of allergens and allergy on the eye. Now we talk about chronic conjunctivitis, which is more of a problem because, as you will see, at least the vernal keratoconjunctivitis part is more of an issue or a problem, simply because of the age of your patients. And of the three varieties, vernal keratoconjunctivitis is the most important, but we also have giant papillary conjunctivitis and atopic conjunctivitis. We'll talk about all three. We'll start off with vernal keratoconjunctivitis, which is the most severe form of an allergic reaction due to environmental allergens that you see in an eye. It tends to last all year round. It's an example of chronic conjunctivitis, and it has seasonal exacerbation just like perennial ones. But unlike perennial, which sort of has, apart from seasonal exacerbation, very low effect on the eye, this thing tends to keep your eye red all year around. But when the seasons are really bad, your eye becomes really, really bad, red, like tomato red. So as I said, the problem with the disease is the age of your patients, and it usually tends to affect young boys. And it usually starts at about the age of 5 or 6. Thus, the difficulty in managing these patients, and it lasts well into the teens or even longer. So the disease lasts for, as you can see, 15-20 years easy. There are basically three types: palpable type, which basically affects the palpable conjunctiva; a limbal type, which affects the bulbar conjunctiva, specifically the part of the bulbar conjunctiva that's around the cornea, the limbal part; or mixed, which has both palpable and limbal involvement. The other thing about the disease is it also involves the cornea, and we'll see how it does that. And there are basically two things. One is that some patients, about up to half of them, develop eventually an ulcer, which is described as a shield ulcer because it looks like a shield used by soldiers in the days of old, medieval soldiers mostly, in upper half of the cornea. We'll see why it develops in the upper half and why does it develop at all. And the other thing is the development of keratoconus. We briefly talked about keratoconus when we were doing refractive errors and astigmatism. Today we'll talk about it in detail. So what is the presentation? You usually have the same presentation as an acute allergic conjunctivitis with a history that's much longer. You have a red sticky eye with an itchy eye and photophobia, which has usually been around for 4 to 5 years, depending upon when the patient presents to you. And it may also be associated with decrease in vision, especially if the history is longer, which is primarily because of keratoconus. What signs do you see? Well, the regular signs: conjunctival congestion, mucoid discharge, tear film disruptions. The palpable form would have cobblestone or giant papillae, depending upon the duration of disease. We talked about papillae formation in allergic conjunctivitis in response to inflammation and edema. Here, they take on a very specific shape, which is called a cobblestone papillae. And if the disease has been around for long enough, they transpose or become giant papillae. We'll see examples of both. The limbal form would have something called Horner's, Trantas, dots. We'll see what those are. The corneal involvement is a shield ulcer, and keratoconus may be seen especially in long-standing cases, as we talked about a bit ago. So these are what cobblestone papillae are, and they are larger and more flatter as compared to your regular papillae, and they're called cobblestone because they look like cobblestones, which are those stones that you see that are used to make those nice paths in your garden or, landscaping stones. These are again examples of various cobblestones. This is just a swab or a Q-tip or ear swab or a Q-tip that's used to hold the eye open. These are what Horner, Trantas, dots looks like. They are basically limbal elevations, and they are basically an accumulation of eosinophils together with debris, inflammatory debris, fibroblasts, epithelial cells. And they tend to happen or occur around the limbus, and as these round elevations, I'll show you more examples here and more examples here. They're sort of becoming sort of gelatinous around the limbus. This is what a shield ulcer looks like, and the theory is, nobody is really sure why this happens, but the theory is that the constant rubbing that the child is doing, because this child is rubbing his eyes almost given the opportunity every time, always, 24 hours a day, because the allergy is not going anywhere. And unless he is on treatment and he follows the treatment, and you can tell him to control the allergies, because the treatment would help a certain bit, but it wouldn't get rid of the itching altogether. There are medications that improve the symptoms a lot, but the only medication that sort of makes the eye white and itch-free is a steroid, and we obviously can't give steroids forever because of their associated side effects. So we tend to give the drugs that we used in acute conjunctivitis and certain other drugs that we will talk about. But irrespective, it's that constant itching, and you close your eyes and you itch. So when you close your eyes, you're rubbing your eye from the top, and that is where this ulcer develops from an erosion to an ulcer, and is filled with that mucoid discharge. That is why it has that gelatinous appearance. And as I said, when we talk about management, the management is difficult because of the age group. It's a pediatric age group, and it's very difficult to tell a child not to rub his eyes. And rubbing is the thing that leads to ulcers and also to keratoconus, as we'll just see. And this disease is not going anywhere, as we saw. Starts when you're about 5 years of age and continues on when you're about 15 to 20. Usually affects males, so that gender by default is difficult to manage anyways. So the most important thing is to talk to the parents and the guardians as well as the child, right? You need to tell them we can control these symptoms, we can't cure them. And unless you tell them, they would move around from doctor to doctor looking for a cure. So you need to tell them this is because of something in the air, something in the environment. We can make it better, we can't get rid of it. And you need to use the drugs as we tell you. There are certain drugs that are safe. There are certain drugs that you need to take with precaution because they have side effects if used in the longer term, irrespective of their ability to improve the symptomatology of the patient. And then you need to tell them to encourage your child not to rub the eye. That is really important. Not rubbing the eye is probably one of the most important things that you can tell the parents or the guardians and even the child, look, that rubbing will make things worse. So you can, make a deal with them, whatever deal works with that particular child. So the therapy is very similar to allergic conjunctivitis, and all of these are topical: antihistamines, mast cell stabilizers, lubricant, cool compresses. Steroids, again with quick taper, they may be used more frequently, but then you need to have more frequent eye examination. So as a family physician, you might prescribe steroids, but tell them to go see an ophthalmologist so he can schedule those regular follow-ups, so he can check your pressure, look at your disc, and also figure out if the side effects are coming up. That is really, really important. If this treatment is not sufficient or you're getting steroid side effects, you can use cyclosporin tacrolimus ointment. Tacrolimus, both of these drugs can be used if either the steroid side effects appear or if the disease is not controlled. Autologous serum is also something that really helps. It's basically your own serum that's been your blood, which has been centrifuged, the serum component removed, mixed with artificial tears, and given as a treatment. But the shelf life of those is really limited, so you have to have really quick follow-ups, because unfortunately pharmacies in Pakistan can't really prepare these, and you need to go to a clinic or a hospital to get these made, but they do work in highly resistant cases. So this is the intensity of your symptoms between minimal and maximal. And remember, the symptoms usually never disappear. In a vernal keratoconjunctivitis, they could be at a minimum level, which is described as a baseline level shown by this line here. And then they can get worse beyond that baseline. So this graph shows what to do at specific times of the year. And for our patient, the worst times are between March and May, and September and October, spring and the return of dry season, with maybe little exacerbation during the rainy weather, simply because when it's the rainy weather, the child might actually want to go out and play. It's a time off, summer vacation, not in the time of COVID when every day is a summer vacation, but that's just not the rule, it's an exception. And obviously every child or every patient is going to be different, so it'll be customized depending upon when your patient would have the worst time of the year and when his or her disease is sort of at a minimum level. So whenever the disease starts getting bad, we add upon our baseline treatment. The baseline treatment that sort of continues is antihistamine, mast cell stabilizers, plus supportive measures, which is cool compresses, sunglasses, caps, etc., anything that prevents that allergen from acting in your eye. And different individuals might have benefits from different things. I know certain individuals who have this little fan, and what they do is those 12-volt fans, or even battery-powered fans, and they keep it here. Some even attach it with a contraption to their cap or to their forehead, and it sort of just blows a breeze past their eyes, and it makes them feel better. So parents do a lot of things for their children. So anyways, whatever supportive measures, plus when the disease's symptoms are really bad, so much so that the child really can't stop rubbing, you add steroids. And when you start seeing things become better, and this is the time when the symptoms sort of become better anyways, you taper steroids. And this is true for both of these exacerbations. For the areas or the time of the years when the exacerbation is really not bad, just tell them to use lubricants more supportive measures, and that really helps. But it's your strong counseling, your ability to effectively communicate with your patients that will come and play a very important role here. And you need to encourage not to rub the eye, your patient, and use supportive measures as frequently as possible. Cool compresses, caps, sunglasses are not really going to hurt your eyes in any way. But you need to get good sunglasses with good UV filters, not just any ordinary sunglasses, because it's the UV filter that's actually going to help more. Any dark glasses would, because they're going to prevent the allergens from getting to your eye, but those with good UV filters, because they irritate an eye more, especially one which has tear film disruptions. So now we need to talk about keratoconus, and keratoconus is very strongly associated with VKC. In fact, keratoconus is strongly associated with any condition in the eye in which the patient would rub his eyes or her eyes, of which VKC is the most important. Keratoconus is basically a bilateral but highly asymmetric progressive disease of the cornea in which your inferior cornea steepens and it sort of starts thinning after that. And it also produces myopic refractive errors, especially myopic astigmatism. And it's called keratoconus because your cornea produces a little cone, as we will see in a bit. So that steepening would produce a little cone in the inferior half of the cornea. I'm writing inferior in italics because it is the inferior half that's most commonly affected. That is why it is called keratoconus, cone-like cornea. And again, as we talked about, myopic refractive errors, especially stigmatic errors, because when your cornea changes shape, remember, it causes astigmatism. And the greater the change in shape, the greater the astigmatism. And again, as I said, etiology is not clearly understood. It's basically other causes. And in fact, all of these causes are associated with rubbing, of which VKC is the most important cause. And the theory is it's just the mechanical pressure that causes steepening. And the way it happens is you rub your eyes when you close them. So this is your eyes before you rub them. And then you want to rub them from the top. So the application of pressure is from the top. So the top part is basically flattening of the cornea, and the bottom part is steepening out and developing the cone. The other causes that are also associated with VKC is Down syndrome, Marfan syndrome, retinitis pigmentosa. Well, we talked about retinitis pigmentosa, and retinitis pigmentosa, remember, the child can't see. Again, it's a disease of the childhood, especially dawn, dusk, dimly lit conditions. And when you can't see, you rub your eyes, as we talked about in refractive errors, which can cause keratoconus, change in shape of the cornea. So how would a patient of keratoconus present, especially in a setting of VKC? Well, it'll be of worsening vision associated with a chronically itchy eye, or any form of eye rubbing if it's associated with an ocular systemic disease. Ocular disease, retinitis pigmentosa, systemic diseases, Down syndrome, Marfan syndrome. And the other hint that you get is if the patient is already wearing spectacles because of totally unrelated to VKC refractive error, that refractive error's prescription will rapidly change because the corneal curvature is changing. By rapid, I mean frequent changes. For example, rather than once or twice a year, 3, 4, or 5 times a year. And this is what keratoconus is. Rather than a nice spherical cornea, you have a cornea that now has a cone. And as you can see, the top part is sort of flat, and the middle and the bottom part is sort of protruding out into a cone, and it's also sort of thinned out, as you can see here. This is the normal thickness shown here, and this is a thinned out thickness of the cornea at the point where it is steepening and forming the cone. This is a patient, and this is the slit lamp view. I'll show you some torch views as well, and you can see the normal appearance or a contour of a cornea, and this is the iris. This is the light being reflected off the iris, and this is the pupil. So this is the light coming off the lens. And this is again the iris. It's a lightly colored iris. And look at how the cornea has now a cone-like projection right here. And it is, look at the thickness here, it is normal. And as we come here, it becomes really thin. The thickness here between the light reflecting off the epithelium of the cornea and the endothelium of the cornea is pretty uniform. Here, this is the normal thickness. This is the light coming off the epithelium of the cornea, and this is the light bouncing off the endothelium. So in between is the thickness of the cornea. As soon as you get to the area of the cone, it thins out simply because of the pressure of rubbing causes this to steepen and stretch and become thinner. So this is just an outline of the two showing the cone formation in keratoconus, or the steepening. Again, a picture showing the cone or the steepening. This is the normal smooth contour or curvature of the cornea. And this is again the same picture as we saw before. I've just cut off the eye and just showing you the contours. This is the bulge. This is the flat part where the patient has been rubbing his eye. And this is the part that's bulging out to form a cone, or steepening out to form a cone. So what signs do you see in keratoconus? And again, these are those signs that are in an established disease. Established is something that is producing all these signs. Why is that important? It's simply because it is possible to have keratoconus without any clinical manifestation, very early keratoconus. And in order to pick those up, you need certain specialized tests we'll just talk about in a bit. So the first sign is a Munson sign. A Munson sign is that cone that is being produced. It produces a notch or pushes the lid out when a person is looking towards his feet, down gaze. There is something called a Rizuri sign. Again, I don't want to put these here. They are here because examiners love asking these. A Rizuri sign is basically an arrowhead-like reflection. And I know you have OSCEs and examiners are not supposed to ask questions out of the air and of their own whim, but you never know. So your Rizuri sign is an arrowhead-like reflection on the nasal cornea when you're shining the light from the temporal side using a pen torch. I'll show you these signs as well. Then we have something called a Charlot sign, or an oil droplet sign. And it's when you're doing distant ophthalmoscopy, you see this abnormal color on ophthalmoscopy. it looks like an oil droplet rather than a nice reddish reflex. Again, I'll show you a picture. And finally, a scissors reflex. And this is something that you pick up on a retinoscopy. Remember, retinoscope is an instrument that you use to pick up a refractive error. And when you're trying to do, you see the reflex of the light turning into a scissor. This is something that is not that popularly used anymore, the scissors reflex, simply because retinoscopy is not done that much. But this is again happening because you have a lot of astigmatism in your eye, and you have a lot of astigmatism because your cornea is steepening, and the curvature is becoming more of oval, extreme oval, as compared to a sphere. This is what a Munson sign is, and as the patient is looking down, you can see how it notches the lid. This is a video of a Munson sign and a Rizzuti sign. I'll show you a Rizzuti sign after this, but it is demonstrated in this video, so I put it here. So look, as the patient is looking down, the lower lid is getting notched, it's getting pushed outwards, getting protruded. This is the Munson sign. So this is the Munson sign. There we go. Close up of Munson sign. Look how the lid is sort of notched where the corneal cone is. And as the patient is looking to the side, you can actually see, if you see this really bright reflex of the light, I'll just bring it up again. Here we go. This really bright reflex of the light at the, sorry, let me bring this picture back to you. Here we go. This really bright light that you see, this is basically looking at the Rizzuti sign from the side, not from the front, from the side. I'll show you what it looks like from the front as well. But this is a Rizzuti sign from the side. It looks nothing like an arrowhead because you're seeing it in a cross section. But I'll show you the proper sign as well. So this is the Rizzuti sign in a cross section. You can see the bulge, and it's a pretty obvious keratoconus. You can see the bulge of the cornea. Again, Munson sign. Look how the lid is being protruded, pushed outwards by the cone of the cornea. Very easy to pick up. Let me just forward this. Again, this is the Rizzuti sign. You're seeing the cross section of the arrowhead here. Let's forward this. This is the other eye. You are seeing the same. That's a bird in my window. I'll deal with it in a bit. This is again the Munson sign. And this is the reflex from the Rizzuti sign, that cross section of the arrowhead. You can come back to this window after seeing the Rizzuti sign from the front and see how it appears here. Here we go. That's the Rizzuti sign from the side, that light that sort of shines up the on the cornea. There we go. That's a very, there we are. Now that looks like an arrowhead, even from a cross section. I'm sure you know where the arrowhead is pointing. Here is the arrowhead. And I'll show you a better picture so that will be more clear. Here's a very brightly lit arrowhead. It's a head of an arrow, you know, like that pointy arrow. Okay, I think we have had enough of these. All right, let's go look at the Rizzuti sign. So this is the arrowhead. You're shining light from the temporal part of your cornea, and at the nasal half, you see this arrowhead right here where the arrow is. This is another one. It's slightly less pronounced than this, but look at how this arrowhead is produced. This is the outline, this is the outline, and this is the one that we were seeing from the side, the cross section from the reflection in the video that we're seeing before. So if you're using a pen torch and looking from the front, like you do a torch examination, this is how that corneal reflex would appear on the nasal side, and that's simply because of the change in shape of the cornea that produces this sign, Rizzuti sign. This is the oil droplet reflex, or the Charlot sign, and as you can see, the oil droplet is a swarm of colors like you see in a drop of oil as compared to a very homogeneous color that you see in a normal red reflex when you're doing distant ophthalmoscopy. Scissors reflex is probably the most difficult to explain. This is a retinoscope, and a retinoscope is used to pick up refractive errors, and it's used nowadays only in individuals who are not suitable to be tested on a machine, the automated refractors. So when you are shining this light, this is your pupillary area, and this is your cornea and the iris. So this is the cornea over the pupil. And because of the extreme astigmatism, the light beam, which is singular, breaks into like blades of a scissor, and they move like a blades of a scissor. I'll show you a video because a video is worth a gazillion words if a picture is worth 1,000 words. So this is how you will see the reflex, the scissors reflex. It will exactly be like blades of a scissors that is horizontally placed, and you will see it on this side of the red reflex through the pupil. Remember, we are looking at only this zone. We don't want to look at this light coming off the iris. We want to see the light coming from the pupillary area. So I'm just going to start the video. Here we go. Just look at this part of the picture. These are your scissors. You see those blades opening up, the black shadow that you see? These are the blades open. And as I move this video really slowly, the blades would close. Blades are open, blades close. Blades open, blades close. These are blades opening and blades closing. So it's a horizontally placed scissor, and it's exactly like this scissor here. So I'm just going to go back to open. These are the blades that are opening up, these black areas. This is a fully open blade, and these are closing up. So this is an open blade. This V that you see with an apex towards the left. And as I move very slowly forward, they close. Open, close, open, close, open, close, open, close. It's like Pac-Man. Pac-Man is probably a better idea than scissors reflex. Pac-Man reflex. I hope you know what Pac-Man is. If you don't, I can put a picture up of Pac-Man actually. So these are open and these is closed. So you can see this video again, but I'm sure I just realized this is more of a Pac-Man thing than anything else. Open, blades open, seen by this V, and as we move forward in time, they close. So this is what a scissors reflex is. I'm putting it here because it's academically important from a point of view of a redundant system of examination. But you never know what might happen in examination or an assessment, and I need to dot my I's and cross my T's. So I brought up the Pac-Man also, and let's see if it looks more like a Pac-Man or scissors, where you make up your mind. So this is the mouth of the Pac-Man open. This is the mouth of the Pac-Man closed. I think it looks more like a Pac-Man than scissors reflex. Anyway, they might not have had Pac-Man when this was actually discovered, so you never know. So this is in real time. So these are the things that you see. You see a Munson sign, you see a Rizzuti sign, you see a Charlot sign or an oil droplet sign, and you see a scissors reflex. All of these were once very popular because those were the signs that basically defined keratoconus clinically. So you saw those signs and say, yeah, you have keratoconus. And early keratoconus was difficult to diagnose because it does not produce those characteristic signs. And you need something called computerized video keratography, which is basically a computer-based testing of your corneal curvatures, which can detect cases with no clinical manifestations. And that is when you want to pick up your keratoconus so that you know, yeah, your keratoconus is now starting. Again, as I said, it's a progressive disease, but we can control the itching to at least try and slow down, or eye rubbing, so try and slow down the progression of a disease, because once it starts, it continuously progresses on. And eventually we would need to start intervening in order to keep good vision. But at least if we are able to pick it up early, we can sort of delay the use of the various tools and assets we have in order to maintain good vision. So for example, rather than going from glasses or spectacles to surgery in 5 years, maybe we can go from glasses to surgery in 7 or 8 years if we pick it up early and we start managing the etiology, i.e. the rubbing, better, or even informing the patients, look, your cornea is starting to change its shape and we need to sort of, manage it appropriately. But at times, even the best efforts managing itching very well would not slow down the progression, and the progression would actually just happen at its own pace. But you need to do things that you can and hope for the best. So the video keratography is various types of machines are used to do this: ARP scan, pentascan, and Galilei. Galilei is the machine, and that's the current standard for studying the corneal curvature. And they're all based on the ARP scan and pentacam, basically on something called a Placido's disc. Galilei is based on more advanced camera system that I'll just show you. And this was a Placido's disc. Placido's disc is old, in fact, at a time when this was powered by the sun. So what you do is you use this peephole and you put this in front of the patient's eye, and through the sun you will get these concentric light and dark bands, because this dark area would not prevent a concentric ring from forming on the patient's cornea through the light area, which is generated from the sun that's falling on the disc. I'm not joking. Yes, the sun. It's that old a device. And you get these concentric rings, and if the rings are sort of symmetrically distant, equidistant from one another, that's a regular cornea. But if you have crowding, that would mean the cornea there is steepening. You have keratoconus. But this is the modern system. So most of the early machines were based on an electronic form of a Placido's disc. The modern system uses multiple cameras to study the anterior and posterior corneal curvatures. So this is basically a corneal topography showing a normal cornea. Remember, the power of the cornea is about 42 diopters, so the most of the cornea here is 42. There's some steepening here, so maybe has a little bit of astigmatism, but look at this. Here we have 64 diopters, means the cornea is really, really steep here. Because remember, the greater the curvature, the greater the power, because it's more rounder, more thicker in that area. So this is how a keratoconus cornea would appear. These modern machines also can tell you what are the chances of keratoconus in this patient. They give you a value, but obviously you read that value with your own clinical acumen. You just don't rely on the machine blindly, because then, we all become slaves to the machine. We've all seen the Matrix. We probably all played Detroit Become Human, but a Matrix is a better example. More people have seen the Matrix. So what can we do to manage keratoconus? Well, depending upon, and this is a chronological order from where you start and where you end up, and depending upon how good a visual acuity you can achieve with these aids. Spectacles is the first thing. As long as you can maintain good vision, which is acceptable to your patients, use spectacles. Beyond spectacles, you have contact lenses, both rigid and soft. We talked about these when we talked about refractive errors. Beyond that, we need to think about more interventive means that are require more intervention, of which the first is something called corneal cross-linking with riboflavin or C3R, and then something which is intracorneal ring segments, which may be combined with C3R, and then finally keratoplasty. So we'll take them one by one. We obviously have done spectacles, so we will not take up spectacles. We'll start with 2 and 3, which is various types of contact lenses. Initially soft contact lenses, as long as they work. When they don't, the corneal curvature is so steep that the soft contact lens won't stay on the eye. So use a rigid contact lens that can sort of make the cornea adapt to the shape of the lens, rather than the lens being forced to adapt to shape of the cornea, as in the example of a soft lens. A soft lens is so flimsy that it would tend to mimic the shape of the cornea, where a rigid lens is made from the same material that intraocular lenses were made, polymethyl methacrylate or PMMA, and they are rigid enough that they can force the cornea to take the shape of the lens, but they would work to a certain extent and then they would stop working. Then you have something called C3R, or corneal cross-linking with riboflavin, which is a very interesting technique invented in one of the Scandinavian countries, I think, in which you deliberately damage the cornea by putting ultraviolet light and helping it rebuild its cross-linking, collagen cross-linking, by using riboflavin, which is vitamin B2, as an accelerant or a photosynthesizer. And this new linking over time can help stop the progression of the disease and may even flatten the cone that was being formed. So I'll just show you a small video of how it's done. This is riboflavin being put in the eye. This is a clip. We've seen this clip before. Riboflavin drops, and then we'll start using ultraviolet light. And this is a pulse light. You don't constantly put ultraviolet light. And this is being done for a fixed amount of time. And once this is done, the patient has counseled and is let go. And this procedure is usually done by ophthalmic technicians as an outdoor procedure. Once the disease is beyond even the control of C3R, you have done glasses, contacts, you tried C3R, the disease is still progressing, or it worked for a little bit of time, but now the disease has gotten worse. The next thing you can try are called intracorneal ring segments. They are basically semicircular rings. I'll show you how they look like, and they're made of the same material as the lens. I keep emphasizing that because the intraocular lens was made of a material that's inert to the eye. It does not react within the eye or cause a foreign body reaction. So that is why these materials, these objects are made of pretty much the same material as rigid IOLs were made. And they're basically placed in the stroma of the cornea, either mechanically or by using a laser. And what they do is they cause a flattening of the cone and reduction of myopia. And since you're actually creating a little tunnel in the stroma of a cornea that's actually already thin, you can combine it with C3R to strengthen the cornea. So I'll show you a little video, and these are the marks where the ring will be placed. This is a little instrument to create a tunnel. Now this is a circular blade that is inserted into this tunnel to create a path for the ring. And it is inserted through the same opening that was created before. And this is a blade. This is not the ring. So this is a circular sort of a blade that will produce an opening large enough, or would create that tunnel for us through which we can produce or place our rings. Once the tunnel is complete, the blade is withdrawn, and now this is what an intracorneal ring segment looks like. So one segment will go in this half and the other segment will go in this half, and they are made of PMMA as it says here. And because you have a tunnel made now, it's pretty easy to just slide them in. And this can be combined with C3R to make things easier, and this is how they would look within the cornea. Finally, keratoplasty. So once the astigmatism is so bad that the vision is not improving, even with all the things that we have tried so far, we need to replace the cornea. And keratoplasty is basically grafting a donor cornea in place of a diseased cornea. Keratoplasty is done in a lot of conditions, as some we'll talk about as we move along in our clerkship. One we are talking about right now is keratoconus. And this is one of the least complicated grafting procedures, simply because the cornea is avascular and you don't need to worry about a lot of tissue matching and typing. All you need is that cornea, and you get a cadaveric cornea. You don't get a live donor cornea. There is no artificial cornea right now, but most of the corneas that we get are cadaveric corneas. Our major issue is not the cost of the surgery. The surgery is relatively easy to perform and it's very inexpensive. You basically need one suture that is something that's used in the patient. Everything else can be used, again, blades and scissors, as you'll see. And it's a relatively cheap procedure. The thing is, Muslims don't donate corneas. You should be, we don't donate corneas because we think we won't go to heaven, but you should. And there are places in Pakistan that help you become a donor. This is my donor card. And you can get one of these from Sindh Institute of Urology and Transplant. They have partner centers all over Pakistan. You can go onto their website, fill this up, but make sure you take relevant permissions from whomever you have to before you do this, and before you get everyone into trouble, including myself, for encouraging you to become donors. Anyways, it's important because once you are dead, maybe what a part of your body tissue that's of no use to you could be of use to someone else. It's a less aggressive version of 7 pounds. So this is how we do keratoplasty, very basic steps. You have your clear donor cornea and a diseased host cornea. For both of these, on both of these, you use a round blade to cut, which is called a trephine. So we cut off the donor cornea as well as the host cornea because we need to change the host cornea. So we remove the diseased cornea, put our new donor cornea in, and suture it. You can put interrupted sutures, and these are 10-0 nylon sutures, something we also saw in cataract surgery, the same suture. These are interrupted, these are sort of continuous. and we'll see a little video. This is the diseased cornea or the host cornea, and this is just measuring the size of the host cornea that is going to be removed, so the donor cornea can be cut to the same size. This is the tree fine that is going to cut our cornea, and then scissors are removed to excise the cornea away after we mark it or cut it with the tree fine. Now our eye is open. This is the anterior chamber. Gel, the same protective gel that we used before, is being put. And now we are going to put our donor cornea, which is nice and clear, and we're just going to put some stitches. Here we go. Again, stitching is the thing that takes the most time because you need to put many stitches so that the cornea is secure. Here we go. So maybe about 16 to 20 stitches, and the stitches are, the knots are being buried so that they don't sort of bug the patient or produce a foreign body sensation. This is not my video. In fact, you get very few Pakistani videos. You get mostly Indian videos. Oh, and this ring is just a stabilizing ring on the eye so that it's slightly easier to perform the surgery. And just while this video plays, sort of again, I wanted to emphasize that not every cornea can be used as a donor cornea. You need to have a certain criteria that needs to be met, especially in terms of infections. If the patient was HIV, hepatitis positive, had bovine spongiform encephalopathy, that mad cow disease, had certain other tumors, including neurological tumors, that person can't become a donor because all of those things can be carried over onto the donor tissue. So there's an entire criteria. Also, you cannot store a donor cornea indefinitely. You have storage medium, short term, medium term, and long term. But as the storage time increases, the corneal quality degrades, because we've talked about the corneal endothelium before and that sodium potassium pump, and as the time frame between removing the cornea and implanting it increases, you do get a little bit of degradation irrespective of how good your storage medium is. The most long-term storage medium is liquid nitrogen. Put your cornea there, freeze it, and that would be a long-term solution which would last for weeks. But again, it's best to sort of use it as soon as you have it. And corneal transplant is something, as I said, it does not require a lot of matching. And at least in the US, they've never had a problem with corneal transplant. In fact, they have so many corneas that they export it, and we get most of our corneas from the US. We used to get them from Sri Lanka, but that has sort of decreased now because of, again, what I talked about, corneal profiling. Are we getting, especially the screening, does this cornea qualify for a transplant or not, is somewhat dubious from Sri Lanka as compared to the US. US corneas are more expensive, but you get what you pay for. So that was all about vernal keratoconjunctivitis and keratoplasty and keratoconus, because it's very strongly associated with rubbing. Now we talk about the second type of chronic allergic conjunctivitis, which is giant papillary conjunctivitis. And this is a type of conjunctivitis that is because of chronic irritation to the eye. And that is mostly because of a ill-fitting contact lens or a poorly maintained contact lens or hypersensitivity to contact lens solution, which is being constantly kept. There are other causes, for example, a prosthetic eye or an artificial eye, or implants within the orbit. We'll talk about implants when we do ocular trauma, and sutures also, because they're all foreign bodies. And it's called giant papillary conjunctivitis because you get these giant papillae. Look at the size of the papillae as compared to acute. These are the same giant papillae that you can get in a vernal keratoconjunctivitis, which has stayed on for quite some time. And remember, initial papillae were cobblestone papillae, which then convert into something like this, giant papillae. Management, the best management is obviously to remove the irritant. If you have problems with contact lens, switch to another contact lens. Problem with solution, switch to another solution. If you can't use contact lens for a prolonged period of time, give yourself a contact lens holiday. Decide these are the 30 days in a year or half a year that I won't use my contacts. Switch to glasses, remove sutures, change the prosthesis. Lubricants and cold compresses are interim procedures. it does respond well to mast cell stabilizers, but it's very resistant to treat otherwise if you really can't get rid of the cause. For example, there's a patient who is persistent on use of contact lenses, and in spite of the fact that you have changed contact lenses, he still has an issue. You can try all of those supportive measures together with mast cell stabilizers. Then it's the third type of chronic allergic conjunctivitis that we need to talk about is atopic conjunctivitis. And this is a patient who has atopy, i.e. genetic predispositions to allergic reactions. And this is associated with other atopic disorders like asthma and atopic dermatitis. And the presentation is very similar to weak SC. And obviously, you are going to get non-ocular allergic symptoms, for example, of asthma or atopic dermatitis. And unlike VKC, where most of the papillae are formed in the upper lid, you can get papillae in the upper lid and lower lid in this disease. And it also might have a little bit of blepharitis. Blepharitis is inflammation of your lid margin, but the management is very similar to weak SC. And it does help. If you have blepharitis, obviously you would need to manage blepharitis with it, but generally the management of allergy or the allergic component is very similar to that of the weak SC. Okay, so viral conjunctivitis is obviously because of a viral etiology, and they are self-limiting, extremely common cause of conjunctivitis. Antibiotics are usually not prescribed in a viral conjunctivitis simply because the preservatives in many of these antibiotics can actually make the viral conjunctivitis worse. It usually tends to come in epidemics because it's a highly contagious disease. So if like this viral pandemic, and the usual mode of transmission is either contacts from fingers to eyes, or it's a respiratory droplet transmission to the eyes, and can affect any age group. The most common organism that causes a viral conjunctivitis is an adenovirus. Herpes simplex virus, measles virus, chickenpox, and rubella virus are indicated, and they are implicated in viral conjunctivitis that's seen in children. The type of adenoviral conjunctivitis that you see is divided into three. You have follicular conjunctivitis, you have something called Pharyngococcal Fever, and you have epidemic keratoconjunctivitis. We'll take them one by one. We'll start off with follicular conjunctivitis, which is the mildest form of viral conjunctivitis. It is not the most common, but the mildest form. The viral serotypes involved are 1 to 11, and the presentation is of a red and a watery eye, with one eye and the other eye following between 3 and 7 days. The reason for the watery discharge is simply because of the lymphocytic reactions, the lymphocytic pathway that a viral infection initiates as an immune response in the body. The conjunctiva is diffusely red. It's at times described as pink, but it is red. And I have seen the eye of a viral conjunctivitis being tomato red. And as we'll see in some of the variants of an adenoviral conjunctivitis or types, you do get a very red eye. You get a follicular lid reaction together with a lymphadenopathy. Lymphadenopathy simply because, again, lymphocytes are recruited. And as we saw a papillary reaction in an allergic conjunctivitis, in the palpable conjunctiva, we get a follicular lid reaction. And that follicular lid reaction is, again, local lymphoid tissue that proliferates in response to a viral infection. The lymphadenopathy usually starts off on the affected sites, and it's preauricular, the lymph nodes in front of the ears. And when the other eye is involved, the lymphadenopathy can obviously start on the other side as well. The management basically is supportive because you have a very quick spontaneous resolution within a week. So you have lid hygiene, cool compresses and lubricants, assuring the patient that this would go away, and also telling him or her that hygiene is important because you need to keep clean, and also ensure that you don't transmit it to others by touching your eyes and touching others. Pharyngococcal fever is the second type. This is the most common presentation, and it is by not the mildest, but the most common, serotypes 3, 4, and 7. The presentation is very simple, very similar to a follicular conjunctivitis, the difference being fever and pharyngitis as added features. So the management is pretty similar. The duration of the disease is a little longer. It's spontaneously resolved within 2 weeks. And because you get longer duration red eye, which might be bothersome for the patient. So you might want to use vasoconstrictors. But the problem with vasoconstrictors is once their effect wears out, you get a rebound phenomena. So the eye becomes even more red. So you have to be very judicious with their use. Encouraging the patient that, look, this will go away, keep your eyes clean, use a lubricant, cold compresses is a much better idea than just blindly prescribing vasoconstrictors. The third type is the viral epidemic keratoconjunctivitis because of adenoviruses. This is the most severe form, and this is because of strains 8, 19, and 37. And what you get here is a red and a watery eye, and you have swollen lids. So now the spectrum of tissue involved is increasing. It again starts with one eye, affects the other eye a little bit later, and you also get a foreign body sensation with decreased vision. Now, how is that happening? We'll just see that. So again, you have diffuse conjunctival congestion, and the eye is more red simply because you might get conjunctival hemorrhages. You have a watery discharge just as before because this is a viral infection. You have a follicular lid reaction. Again, because it's a viral reaction, the local lymphoid tissue proliferates in the lid. I'll show you some pictures. You have preauricular lymphadenopathy, just as we did before, but this time the disease also starts affecting the cornea, thus Corado conjunctivitis. And the way it affects the cornea is that initially it produces small corneal defects, corneal erosions, and that usually is seen around day 7. And those erosions are then replaced by subepithelial opacities. And those opacities can basically interfere with vision formation because they sort of prevent the light from optimally reaching the retina. That happens about 2 weeks into the disease, and they tend to persist even after the conjunctival inflammation is gone. And that is why it is very important that you tell these patients, look, if you think your vision is sort of going bad, you need to come back so that we can appropriately manage that thing. Because not everyone would have severe enough of a corneal involvement to warrant treatment without the cornea being involved. So you don't want to start, the treatment is steroids. So you don't want to start steroids unless in epidemic keratoconjunctivitis you start getting corneal involvement that is significant enough. So we need to keep a close watch on these patients. The management is, again, the resolution is longer. The duration of the disease is longer. It's about 21 days. The supportive measure stays the same. For corneal opacities, you need to use steroids, and they need to be used for a slightly longer term period because they tend to linger on. As I said, the main disease goes away, but these corneal opacities tend to linger about. So the duration of steroid use is a little longer, and you need to use steroids because unless you stop that antigenic reaction, remember these opacities are thought to not arise because of corneal infection. It's just an antigenic reaction to the viral infection that causes these opacities. So we need the steroid to stop the inflammatory reactions. Otherwise, these opacities will continue to get larger and interfere with vision formation. So corneal opacities tend to linger on long after the conjunctival inflammation has run its course, thus the longer duration of requirement of topical steroid. The other types of viruses that cause conjunctivitis are herpes simplex, which is a primary infection by herpes simplex, and this is usually seen in children. It's self-resolving. In fact, it's so mild that many of the times it's not even noticed. Rubella also causes a follicular type of a conjunctivitis, and it's usually associated with the systemic disease, German measles, or that skin rash that you get for between 3 and 5 days. So this is what an eye of a follicular conjunctivitis would look like. It's just sort of red and a watery discharge. Obviously, you can't really see the watery discharge well because it's something that's so profuse that the patient tends to clean it all the time. This is the follicular reaction. Do not confuse follicles with papillae. Papillae were red top lesion. Follicles are white lesions because this is lymphoid tissue. This is lymphoid proliferation in the local lymphoid tissue of the local lymphoid tissue in the lid, secondary to a viral infection in this case. So these are what papillae look like. We saw them in allergic reactions of various types. This is what a follicle looks like. So again, it's a little bit of description of what a follicle is and what papillae is, what's a papillary conjunctivitis, what's a follicular conjunctivitis. So you can read them from here if you are the sort of a person who would like to, get into the nitty-gritty of things. These are those opacities in the cornea of epidemic keratoconjunctivitis. And these are the ones that can affect in vision formation, provided that they are enough on a visual axis and enough in number so actually has to interfere with vision. But they do require a steroid topical steroid installation to manage, because without them they were not going to go away. But you don't put a steroid in unless you see these, because there is no role for steroid in a viral conjunctivitis because it's a self-limiting disease. Why do you want to suppress the immunity? You only start using a steroid because you don't want this immune reaction in the cornea. And again, this is not because of a direct viral infection, it's because of the antigenic effects of the viral infection. Now we're going to move on to the bacterial conjunctivitis, and as we saw this rather elaborate classification into acute, hyperacute, and chronic varieties, they are not that difficult actually, and under any circumstance to understand, as you will see. Acute is because of the organisms that you're seeing, Staphylococcus aureus, Staph pneumoniae, and Haemophilus. Hyperacute is Neisseria gonorrhoeae. It may be caused by Neisseria meningitidis, but it's very mild. And this is by far the more commoner of the two organisms. And you can also get a chronic type of a bacterial conjunctivitis, which is because of Chlamydia trachomatis. It's an atypical bacteria. You can also get a chronic staph or a strep conjunctivitis if it remains for a long enough time, but that's not something that you usually see these days. So we'll start off with acute, and acute is a self-limiting, rather common infection of the conjunctiva, and usually self-settles unless the patient is immunocompromised. And then the conjunctivitis can actually turn into a keratitis. Or if the organism is very, very virulent, like Neisseria, if you do not properly treat a Neisserial conjunctivitis, it tends to become a keratitis because it's a strong enough organism and it can invade the cornea from the conjunctiva. It's again very contagious and easy to spread. When you touch your eye, you touch someone else. So finger spreading is pretty common. And it, again, like with viral conjunctivitis, it can affect all age groups. Let's talk about acute bacterial conjunctivitis. Again, it's a common form of conjunctival inflammation. The usual presentation is a foreign body sensation together with irritation, redness, and eyes that are sticky, matted together. The eyes at times might also be a little itchy, and that's simply because the breakdown products of bacteria, those antigens, incite a little bit of an allergic reaction. So you also might see some papillae formation. It starts with one eye and involves the other eye rather quickly as compared to a viral conjunctivitis, and that's simply because bacteria are quick to replicate. Viruses have an incubation period, need to be intracellular. So the period of spread, or the time between the two eyes, is the spread of the infection from one eye to the other is less in bacterial as compared to viral. The signs that you see are generalized conjunctival congestion, a mucopurulent discharge this time, simply because we are recruiting neutrophils rather than lymphocytes. And the discharge is sticky enough, purulent enough to mat the lashes together. It's also called gluing of eyes. You have tear film disruptions simply because of the reasons that we have been talking about. You have conjunctival inflammation, which interferes with mucin production and tears sticking to your cornea, and you have a mucopurulent discharge that's also affecting your tear film. So you get that foreign body sensation. And you might have papillae formation just because of those hypersensitivity to bacterial antigens, as we talked about the eye being slightly itchy in a bacterial conjunctivitis. So this is a bacterial conjunctivitis. This is the mucopurulent discharge, bacterial conjunctivitis, mucopurulent discharge, and the conjunctival congestion. Obviously, there is conjunctival congestion in both eyes, but I've just pointed out to the discharge in this picture and congestion in the picture to the right. But you see both things in both eyes. So what do we do? Keep the eye clean. The eye is sticky, it's irritating to the patient, so keeping it clean to remove the discharge is the first thing that you do, and it also prevents the infection from spreading. Topical antibiotics are usually not required. They are only given to hasten the resolution and also to decrease the severity of infection, and it's usually about 7 to 10 days. In adults, you can use fluoroquinolones, chloramphenicol, aminoglycosides. In children, we avoid fluoroquinolones and chloramphenicol because there's only one reported case of bone marrow suppression because of prolonged topical use of chloramphenicol, but even one case is one case. Fluoroquinolones are generally not used in children because they tend to prevent suppression. They tend to suppress growth of the growth cartilage in the bone. So use aminoglycosides. Topical aminoglycosides are the most common type of antibiotic that's prescribed in Pakistan to children. It's relatively safe. You have supportive treatment that we have talked about before, lubricants, cold compresses, and they work really well. Now we'll move on to hyperacute. Should have started with hyperacute, but a hyperacute bacterial conjunctivitis is a severe form of bacterial conjunctivitis that has the potential to cause sight loss if not properly managed, and we'll see how that happens. And the most common organism that causes a hyperacute bacterial conjunctivitis is Neisseria gonorrhea. In rare cases, it can also be caused by Neisseria meningitidis, but that disease is much, much milder and rare in adults. This can be of a neonatal variety in which the transmission is from the birth canal to the baby, and an acquired variety in which you have sexually active young adults with a lot of orogenital contact, meaning you touch your genitals with your hands or your fingers and then you touch your eyes, or an oculogenital contact as well, or with the genital secretions. So the presentation is very similar to an acute bacterial conjunctivitis, with the difference that the disease is much more severe, the discharge is much more copious, and it reappears within minutes of cleaning the eye. And if you do not appropriately manage it, the conjunctivitis can potentially lead to a keratitis, because the conjunctiva terminates at the limbus, and right next to the limbus is the conjunctiva. And because this is a severe form of infection because of a very potent and a virulent organism, it can cause a keratitis. So its management and its treatment must be appropriate and done at the right time. And the treatment is rather simple. For Neisseria gonorrhea, it's a single dose of intramuscular ceftriaxone to the mother and baby. To the adult, it's 1 gram injection. To the baby is by weight. For Neisseria meningitidis, it's the same, but with an intravenous route of administration. So this is a baby with the hyperacute bacterial conjunctivitis. Look at the amount of discharge compared to the eye, and the eye had to be forced open because it is produces such a lot of discharge that that mats and makes your eyes stick together. And this is with the eyes closed, and you can look at the amount of discharge that the eyelids and the eyes have, simply because of the virulence of the organism. This is in an adult, and again, look at the amount of discharge and the congestion. It's basically the discharge is telling you the severity of the infection, thus hyperacute bacterial conjunctivitis, and thus the urgency in its treatment. It's not a topical antibiotic that helps. You need to give intramuscular for gonococcal infections, and for meningococcal, it's an IV route that has to be taken. Chronic. The chronic conjunctivitis is caused by Chlamydia trachomatis. It is a conjunctivitis of a duration greater than 3 weeks. And it is also called a chronic follicular conjunctivitis. And you would be saying, hey, follicles were viral. This is a bacteria. But this is an atypical bacteria. This is an obligate intracellular bacteria that forms inclusion bodies that you can stain with iodine. And you get 2 types of infections, a neonatal and acquired. Neonatal is again through the birth canal, just like the hyperacute bacterial conjunctivitis. And the acquired is of 2 types. One is called trachoma, which is caused by serotypes A to C of Chlamydia trachomatis. And the other one is called inclusion conjunctivitis, or adult inclusion conjunctivitis, which is between serotypes D and K. The trachoma, as you can see of the countries listed there, we are not there anymore. Trachoma used to be in Pakistan once, but thank God and thankfully we don't see it anymore. The reason we are putting the disease here is because maybe a little bit of historical significance, maybe a little bit of nostalgia, and it's still a part of your assessment, so we have it. And this spreads because of oculogenital transmission. You have lots of people living together with really poor hygiene, so dirty hands on eyes, and it usually is seen in children and again crowded living areas. Inclusion conjunctivitis or adult inclusion conjunctivitis are sexually active young adults, and it is of a lower virulence, so it's not as does not produce the effects that the trachoma part would produce. Trachoma is something, once it gets into its chronic stage, can cause sight loss and pain and a foreign body sensation as well. Okay, so let's look at neonatal. This is the most common type of neonatal conjunctivitis in the US. The good part is it's usually self-limiting, and the transmission is from the birth canal, just like hyperacute type of infection. The symptoms you don't get immediately, but somewhere between birth and 14 days. It could be one eye or both eye, and the presentation is with your usual signs of conjunctivitis together with swollen lids. The discharge is initially watery because remember, this is an intracellular organism, so it's a lymphocytic reaction preceded by a neutrophilic reaction. So you have conjunctival congestion, mucopurulent discharge, lid edema, and the management is simply to the baby erythromycin syrup 4 times a day, 50 milligram per kilogram for 14 days. And for the mother, it's azithromycin 1 gram single dose oral. If you apply tetracycline ointment to the baby's eye right after birth, the chances of developing this type of chronic conjunctivitis is much, much reduced. The acquired types of chronic bacterial conjunctivitis for trachoma and adult inclusion conjunctivitis. We'll do trachoma first, then we'll do adult inclusion conjunctivitis or inclusion conjunctivitis. Trachoma is caused by, again, chlamydia trachomatis, but we are talking about serotypes A to C. The presentation, the first time the patient gets it, is just that of red and a sticky eye, very similar to a bacterial conjunctivitis. Signs are conjunctival congestion of the diffuse type together with mucopurulent discharge, and it usually just goes away on its own. Remember, these are countries where access to healthcare is not top of the line, so these individuals usually do have very little in terms of proper healthcare. So the disease is really self-limiting. They have this disease for a little bit and then it goes away and they're happy. Obviously, cold compresses and lubricants help if you want, if supportive therapy is there. But the problem is these infections tend to occur again and again. So it has this issue because the individual is living in the same environment, lots of people close together, poor hygiene. You get it once, then you can get it again. And once you get it again and again and again, then you start seeing problems. And recurrent infections or second and third infections usually produced a very staged and a different response in the eye as compared to the first infection, which we described above. The repeated infections usually start off with a follicular reaction. Again, remember, this is an obligate intracellular organism, and it is also called a follicular conjunctivitis, followed by very intense inflammation, your conjunctiva becoming diffusely red and mucopurulent discharge, and that inflammation then becomes chronic, and chronic inflammation, the hallmark of chronic inflammation is scarring, so you start seeing scarring in your palpable conjunctiva as well as your bulbar conjunctiva. In the palpable conjunctiva, the scar is called an Arl's line, which is a horizontal line on the palpable conjunctiva. I'll show you a picture. Herbert pits are basically scarred follicles around the limbus. This Arl's line, which is basically that scar on your palpable conjunctiva, eventually would lead to fibrosis. And once scarring is fibrosis, once that fibrotic band starts contracting, it would turn the lid margin inwards, leading to entropion, which is the lid margin turning inwards, and also inward turning of lashes, which is called trichiasis or trichiasis. And these lashes, as they constantly strike against the cornea, would cause corneal erosions and corneal ulcers, which would heal by scarring and cause sight loss or corneal opacities. So this was FISTCO, FISTCO. That is how WHO at one time used to classify this disease according to the stage response and which stage of the disease that the patient is in. But this is only happening when you have repeated infections, and this was a problem with the disease. The individual after the first infection became okay, but because he was living in the same environment, kept getting these again and again, and with each successive infection, the disease got worse and worse, gets worse and worse. So these are, again, follicles, and follicles of trachoma are very similar to the follicles that you see in the viral infections. That's why I've used the same picture. Rather than a circle, I've put an arrow here. This is the Arl's line, and this is a very organized scar that eventually would occur because of the fibrosis or because of the chronicity of inflammation, leading to scarring and fibrosis. And once this scar would contract, it would turn the lid margin inwards. And before we see the lid margin turning inwards, these are those Herbert spits, which are scarred follicles at the limbus. They are sort of little pits covered by a clear conjunctiva. This is a close-up of your Herbert spit. And this is what a trichiasis or trichiasis is. Your lashes are turned inwards because the scar contracts, your cornea develops erosions and ulcers, and then finally it becomes opaque. You can see opacified vascularized corneal opacities. These vessels are running on the corneal surface. Cornea is avascular normally, and these are just coming here to heal the cornea, which is getting damaged because of the eyelashes that keeps on rubbing it. Imagine a viper against your windshield constantly running, irrespective if there is rain or not. It will scratch the windscreen. These lashes are really, really tough, and they will erode your cornea and then ulcerate your cornea. Erosions are something that are anywhere in the body limited to just above the basement membrane of the epithelial or the lining, like you have gastric erosions. And ulcers are something when you go below that lining. So the same is true for the cornea. You'll talk more about it when we do keratitis, but right now this is what would happen eventually in trachoma, but thankfully we don't see this in Pakistan. So the best thing to do is to break the transmission of the disease, which is to hand wash, good hygiene, followed by oral azithromycin 20 milligram per kilogram body weight. We are doing it in milligram per kilogram because remember, these are usually children who are getting it, single dose. You can use lubricants or epilation. Epilation is remover of lashes. I'm sure many of you knew that. For trichiasis, and if you have entropion, you need surgical correction for that. If you develop corneal opacities, keratoplasty is the way to go. We've already talked about keratoplasty in the context of keratoconus in this very session. This is the other acquired type of chronic bacterial conjunctivitis, which is adult inclusion conjunctivitis or inclusion conjunctivitis. It's called adult inclusion because it's in an older demographic. It is serotype D2K of the same organism, Chlamydia trachomatis. It's spread the same way, but these are sexually active young adults, and you have a very similar presentation to a bacterial conjunctivitis, red sticky eye, but it runs a more chronic course. And together with the eye infection, you obviously have a genital infection because of chlamydia, which is a cervicitis or urethritis, and this tends to persist longer. But because the individual is older, so the immune response is stronger, so you usually don't have with those complications that you do with trachoma. And the management is single dose of 1 gram azithromycin. So these are all the various types of allergic conjunctivitis that we did. Not the allergic, all types of conjunctivitis that we have done, allergic, viral, bacterial, and how do we differentiate them. This is a tabular review of what we have done, and this I have sort of experienced myself, because when I was an undergraduate, I created my own tables. I'm not tooting my own horns, and tables are a very good way of recalling information very quickly, because there's a lot of information that you can access instantaneously. So this is a tabular review of the management that we have done for all the various types of conjunctivitis. We've gone over acute allergic, chronic allergic. We're just doing the VKC type because that's the most common, viral, acute bacterial, hyperacute bacterial, and then finally chronic bacterial. Just go over these to have a very quick review of what we have done so far. Just a few review pictures. See if you can pick what these are. I'm not going to give you the answers. I'm sure you know them. Now we'll talk about episcleritis and scleritis. Just a few words. They are not that high yield of a topic at undergraduate level, especially scleritis. And just to quickly review what we have done so far, the anatomy of the Epi Sclera was, it is below the conjunctiva. It does not cover the cornea. Conjunctiva also does not cover the cornea, and it tends to surround all of the sclera from the limbus all the way back to the optic nerve. It's a very vascular tissue with multiple levels of vascular plexuses. So episcleritis is simply inflammation of episclera. It is something that's associated with discomfort and not pain. Most of the time it's idiopathic, unknown cause, but it can occur secondary to a dry eye or many autoimmune disorders. The presentation is of a discharge, irritation, watering at the discharge, and discomfort, and you have redness. Redness could be of 3 types. It could be sectoral, it could be nodular, and it can be diffuse. Now, these two, sectoral and nodular types, cannot be confused or mixed up with a conjunctivitis. This one can, because the other two things, watery discharge together with discomfort and irritation, are something you would see in a viral conjunctivitis. And you would like to differentiate between the two. Although the conjunctiva is superficial and Epi Sclera are deeper, it's very difficult to pick up with a torch. So what we do is, and this picture gives a big hint, what we do is we use a vasoconstrictor, a weak vasoconstrictor like 2.5% phenylephrine, which is a sympathomimetic agent. And this weak agent will only penetrate to the conjunctival layers and not the deeper layers. And since it's only penetrating the superficial layers, if you put a drop of this in and the eye blanches, becomes clear, you know it's a conjunctivitis. And the pupil is dilated because the effect of the sympathomimetic on the dilated pupillae muscles, which dilates the pupil, that's a big hint as to why the pupil was dilated in that picture. So how do we manage it? If there is a dry eye, you manage it. If you have an autoimmune disorders, DMARDs, we'll talk a little bit about DMARDs when we talk about scleritis. Idiopathic is just lubricants. If lubricants are not enough, give non-steroidal anti-inflammatory drugs that do work to shorten the course of the disease. It would go away even if you don't give non-steroidals. Now we'll talk about scleritis, and scleritis is a disorder of inflammation of sclera, inflammation and necrosis of the sclera. It's of two types, anterior scleritis and posterior scleritis. Anterior scleritis is anterior to the insertion of recti muscles. Posterior scleritis is posterior to the insertion of recti muscles. We usually limit our discussion to anterior scleritis at an undergraduate level, which is inflammation of the sclera anterior to the insertion of extraocular muscles. It tends to be a unilateral disease mostly, but it can shift between eyes, but you can see it in both eyes at the same time. It is strongly associated with autoimmune diseases and connective tissue autoimmune diseases like rheumatoid arthritis and SLE. Its autoimmune disease association is very different from autoimmune disease association of uveitis, which we will do later on, and you will see that, which is actually sort of good because the presence of a systemic disease can actually give you a good hint as to what's going on in the eye. It can also be because of infections, but it is rare, so it's mostly an autoimmune process. You usually see it more in females than males, usually 6th decade or later, but it can be present earlier. So how do the patients present? It's with a red and a painful eye with variable degrees of reduced vision. Reduction of vision would depend upon how severe the disease is. And it can be, since it's an autoimmune associated with an autoimmune disease, the period of active symptoms can be from months to years. And because the muscles are attached to the sclera, as the muscles contract and exert a traction on the sclera, and the sclera is inflamed, the pain becomes worse on eye movement. There is one variant of scleritis that does not have any pain, and that's called Scleromalacia Perforance. It's a very rare but a very malignant type of anterior scleritis that quickly destroys your sclera, and it's a very strong association with rheumatoid arthritis. As we have talked about before, degree of visual reduction would depend upon the duration of the disease, and the visual reduction is not because something is happening to the sclera. The sclera has nothing to do with vision production. It's the extension of the inflammation to the underlying choroid. And again, when we'll do uveitis, when we talk about it a little more, these eye tissues are packed very close to one another. So if you have inflammation in the sclera, there is a good chance it will transmit to the choroid. Similarly, problems in the choroid can transmit to the retina and rarely to the sclera. And this is because the tissues are very closely packed together. The good part is that if you treat this condition well, the vision usually tends to be preserved for quite a long time. The other symptoms that you get is watering and irritation, and that's just because the sclera, together with its overlying tissue, become inflamed. Remember the closely packed nature of these tissues. So it's of three types again: a diffuse type, a nodular type, and a necrotizing type, the Scleromalacia Perforance. Here you can see the entire sclera is destroyed. You can see the underlying uveal tissue. This is choroid, and this is all the necrotic sclera around it. The diffuse type is again something that can be confused at times with an episcleritis, but it's easy to separate between this and conjunctivitis simply because scleritis has a lot of pain associated with it, which conjunctivitis and episcleritis don't. But pain is again a very relative term, especially if you don't take a good history and a good understanding of what a patient perceives as pain. Remember, many people think, even many doctors think, that refractive errors is associated with pain. It's not. We talked about it. So again, the thing is conjunctivitis, episcleritis, or scleritis. What are we looking at? And rather than using a weaker solution of a vasoconstrictor, we use a stronger solution. And a stronger solution is able to penetrate both the conjunctival and episcleral vessels. So if you have scleritis and you use a 10% solution, the conjunctival and the episcleral solution vessels would blanch, but not the scleral vessels, and they would remain as such, and you can tell that this is a scleritis that you're looking at. So how do we manage it? Since it's associated with connective tissue disorders, you need a rheumatologist. And in fact, it's the rheumatologist that's most of the time treating this disorder, because the treatment that works for the systemic connective tissue disease also helps to control the inflammation in the eye. And as you can see, oral, it's oral drugs that work here. Starting from non-steroidals to steroid to methotrexate to cyclosporine. Again, it's the rheumatologist that is the best judge of what to give. If you have a lot of thinning, like we saw in the case of necrotizing Scleromalacia Perforance type, you can use a piece of graft tissue to cover it. It could be a donor sclera. It can also be fasciolata or a periosteum. Fasciolata and periosteum are much more commoner than a donor sclera as a grafting tissue. So this is a table that helps differentiate various types of red eye presentations. These are those things that can easily be seen with a torch and taking a history from a patient, even a short history. So you see this table, it will help you differentiate between various types of red eyes that we do. We'll do some other red eyes in addition to these. We'll create our own table for those. Thank you very much. If you have any questions, you know where to ask.